So I'd like to introduce to you Charles R. Mills, Doctor, MD, and he's board certified in internal medicine and rheumatology. Dr. Mills has completed his medical degree at Loma Linda University in Loma Linda, California, and he trained in internal medicine and rheumatology at the University of South Florida in Tampa, Florida. He is currently employed at Mercy Medical Center in Rogers, Arkansas, where he works as rheumatologist and as associate professor for the University of Arkansas for Medical Sciences. He is also the vice president and medical director of Abundant Health Wellness Center, and Dr. Mills is currently studying to be board certified in lifestyle medicine. He is the father of 3 children and is married to a physician, Omi Mills. So we want to welcome Dr. Mills.
I was kind of half expecting somebody else to come up here with that intro. Let me get started. All right, that one doesn't exist. Okay. So, contrary to what Dana said, you can just call me Chuck. I respond better to that. A couple weeks ago, Dana, you know how persuasive she is if you know her. She asked me to do this talk, right, on cardiovascular disease, and I reluctantly said yes, and the rest is history. But I will say, it's a big topic, right? The more I studied, the more I realized just how big it really is. So you're going to get an overview from like 30,000 feet up. And there's a couple bullet points that I found interesting. I got to learn quite a bit in this talk. So, you always learn more putting it together than actually listening to me babble. So it's kind of neat. But if you guys want we're going to try to, any information that you see on here that's relevant, we'll try to make that available to you guys. Okay, so heart attacks are no joke, usually. So I don't know if you remember Sanford and Son. That was one of my favorites growing up. I can't tell you anything about it right now, but when I was a kid, it was interesting. There's been a lot of famous people who have actually died from an MI. An MI is another way to say heart attack. It's myocardial infarction. So throughout this talk, you'll see me refer to MI or heart attack or back and forth, but it's the same thing. So Red Fox, actually the one on the last slide, actually did die from a heart attack at 69. We have Orson Welles, J. Edgar Hoover, James Gandolfini, Luther Vandross, and look, some of these people are pretty young. 52, 54. John Candy was only 44. Michael Clark Duncan just recently passed a few years ago, and he was 55, and he was in pretty good shape. And famous people that have had a heart attack, Bill Clinton, on down the list, Regis, Barbara Walters, Burt Reynolds, Kelsey Grammer, Rosie O'Donnell, and then John Warner, the doctor that we just showed you that video. He's the head, I don't know if you missed it, but he's the head of the American Heart Association. He's the president, and he's up there giving his speech on heart disease, and that night he actually had a heart attack and literally died. He got resuscitated. It's quite a story. So he's lucky that he just happened to be in that setting with a lot of people that could help him. So who's at risk of having heart disease? Well, most of us are. So about 610,000 people die from heart disease every year in the United States. That's literally 1 out of every 4 people. Heart disease is the leading cause of death for both men and women. Coronary heart disease, so that's like a heart attack, kills 370,000 people in the United States every year. There's 735,000 heart attacks every year, and 525,000 of those, that's their first heart attack. 210,000 are repeat offenders. I thought this one was interesting. This is the heart attack death rates. Okay, so across America, red is bad, and you can see we're just about the reddest state, actually. So we're right in the belt of all this, and you'll find the same looking picture for high blood pressure and for diabetes and obesity. Somehow they all kind of go together, and you'll find out why. I want to back up and just say, okay, how do you know when you're having a heart attack? What are your symptoms? How do you know if somebody else is having a heart attack, right? So let's go over the symptoms, okay? It's important to know because the earlier that you get it treated, more likely you are to survive, okay? In 2005, they did a survey, and most people that they asked, 92%, knew that chest pain was a possible heart attack, right? But only 27% knew all the symptoms. And they knew to call 911. A lot of people don't even know to call 911 with that. 47% of people that have a heart attack don't make it to the hospital, right? So that's a pretty impressive statistic. It's really ominous when you think about it. So the reason being is some people don't know that chest pain is important. They don't know that if they're having a heart attack, they don't recognize it, and then it gets them before they make it to the hospital. According to the National Heart Attack Alert Program, these are the major signs of a heart attack. So let's go through this. Chest pain and discomfort, right? That's the first thing you think of. So most heart attacks are in the center on the left side of the chest. They last for minutes, and they can kind of come and go, right? It's the discomfort. It's more like a discomfort than a real pain. Most people say it's like a pressure, squeezing, fullness, that sort of thing. They use those kind of descriptive terms. Some people even say like an elephant sitting on their chest. Right. You can have pain in other areas of your body. It can go down either of your arms, actually. It's not always just the left one. It can go through to your back, your neck, your jaw, even your stomach. Usually have some associated shortness of breath. And you can get a cold sweat, nausea, lightheadedness. This is pretty obvious sometimes. If you know what to look for, these things are it's a big constellation of symptoms. You don't have to have them all either. Here's another way to look at it. I found this in another place. It's OPQRST. So if you like mnemonics, onset. So it's usually gradual, but the symptoms can wax and wane. Provocation and palliation. So usually what that means is, if you're doing something, you're exercising, that sort of thing, that's when you get the chest pain. That's when you have the issues. Okay. Quality, it's usually dull. It's pain, it's squeezing. It's more discomfort than pain, like I said. It's tightness, pressure, heavy, feeling like an elephant. It's not sharp. It's not stabbing. It's not pins and needles. Radiation, like we said, it can go down your arm. It can go up your neck, go through to your abdomen, your teeth, different things like that. It's not usually above the nose or below the navel. And its site can be anywhere in your chest, but typically it's almost like the entire thing. And it usually lasts more than 20 minutes. There's always exceptions to the rule, and this is where it gets complicated. So they did a study on 430,000 people with known heart attacks. They reviewed that, and a third of them didn't have any chest pain at all. They reported no chest pain. Often they just have shortness of breath or weakness, nausea, vomiting, sometimes epigastric pain, which is in the center, palpitations, or even sometimes they pass out. So you got to watch out for these people, diabetics, elderly, and women. They have that more often. And she looks like my grandma. Actually, my mother-in-law. No, I'm just kidding. I hope you can edit that out. All right, sorry. Okay, so this is not likely chest pain. This is probably not cardiac. Okay, so this one's pleuritic type chest pain. So it's worse when you take a deep breath. Okay, that's a clue. That's probably not your heart. Mid or lower abdomen, so if it's below your belly button, then it's probably not. Okay, so some people say it radiates down their legs, stuff like that. It's probably not your heart. A pain that you can reproduce with certain movements. You move your shoulder, or you reach one way, and you get the chest pain that comes back. That's probably not your heart. If you have chest pain for days or weeks, it's not your heart. You'd be dead, right? If you have fleeting pain, it's just a few seconds, sharp, or something like that, it's not your heart. And then, but those can be serious too, obviously. So if you're ever in doubt, go check it out, right? So if you ever call me and say you're having chest pain, I'm probably going to say go check it out, because it could be something, it could be something else. It may not be your heart, but it may be something else. So you got to get checked out. Okay, so I had a patient come see me. He's 62. He has some he was nausea, and he had some stomach pain for the last 2 days, solid. He had no chest pain, no discomfort in his chest. His symptoms were bad enough to go to the emergency room. So he was one of those guys, I said, go to the emergency room, right? So he got worked up, and he did have a heart attack. It was a pretty severe heart attack. He was found to have 4-vessel disease. So if you know what that means, that all 4 big vessels in his heart were clogged up. So they had to do a bypass. He had some complications and ended up being in the hospital for like a month. So what were his risk factors? His age is one. He's 62. Being a male is actually a risk factor. They have a little worse than females. He has high blood pressure. He was taking blood pressure medicines, but it still wasn't really quite controlling his blood pressure, and he just kind of let it go. He had some kidney disease, probably from the blood pressure. His weight was a little high. His BMI is 31.9. Normal's 20 to 25, right? Maybe even less if you're Dana. So he had a sedentary lifestyle. So he didn't do much exercise. He walked a little bit, but he wasn't really making a full commitment there either. Cholesterol doesn't look too bad, right? 183, that's not too bad. Triglyceride, little 128. His good cholesterol, though, was on the low side, and his bad cholesterol was just a little bit high. So let's go over the risk factors for heart attacks. Age, men over the age of 45, women over the age of 55 are more likely to have heart attacks than younger people. Smokers, smokers and long-term exposure to secondhand smoke increases the risk of heart attacks. Some of this stuff is an overview. I know you know a lot of this. High blood pressure. Over time, high blood pressure can damage your arteries that feed your heart by accelerating atherosclerosis. High blood pressure that occurs with obesity, smoking, and high cholesterol, diabetes increases your risk even more. So if you have these other factors, they kind of play together and make things worse. It's like the perfect storm. Okay, high cholesterol, triglycerides. A high level of the bad cholesterol, the LDL, is most likely to hurt your arteries and clog your arteries. High triglycerides, it's a type of fat related to your diet, also increase your risk of a heart attack. However, the good cholesterol, the HDL, is actually protective if you have it high enough. Diabetes, like Dana covered. Insulin is a hormone secreted by your pancreas and allows your body to use the glucose in a form of sugar. Having diabetes increases your risk of heart attacks. Family history is important, so if you have a parent or a grandparent that have had a heart attack, if there was by the age of 55 for a male and 65 for a female, that increases your risk. And then the lack of physical activity is an inactive lifestyle. It not only it's bad in a lot of ways, but what it does is it increases your cholesterol and increases your obesity risk. People who get regular aerobic exercise have better cardiovascular fitness, which decreases their overall risk of having a heart attack. It's also beneficial for lowering your blood pressure. Okay, obesity is associated with high cholesterol, high triglycerides, and losing just 10% of your body weight can lower your risk of these things. Stress, who doesn't have stress, right? But that increases your risk for heart attack. And then illegal drug use, anything that's a stimulant like cocaine, amphetamine, those kind of things, they trigger spasms in your coronary arteries and can cause a heart attack too. And if you're a woman and you had preeclampsia during pregnancy, that can increase your risk. And then autoimmune disease, this is something that I do all the time. Rheumatoid arthritis and lupus, things like that increase your risk of having a heart attack and makes your blood more apt to form a thrombosis or a clot. So back to my patient. Now that we know a little bit about those risk factors. He had the age, the high blood pressure, lack of physical activity, and obesity in this list, right? So some of those risk factors are kind of out of your control. So he can't do anything about his age or his family, right? So we like to focus on the modifiable risk factors. And this is what most of us should really focus on, the things that you can do something about, right? So they did a study that's called the Inner Heart Study. It involved 52 countries, so it's a big study. They reviewed all the things that were associated with people that had heart attacks. They found 9 contributed to 90% of the risk of a first heart attack. And then the ones we just went over, so smoking, hypertension, high cholesterol, diabetes, lack of activity, abdominal obesity, and a lack of fruits and vegetables, believe it or not, and psychosocial factors like stress and then alcohol use. Okay, so then if you want to look at it even really closer, there's 5 here that account for a major portion of it. These are the ones I want to really focus on. So high cholesterol, they said that it accounts for like 49% of your risk of a heart attack, your first one. Tobacco use was 36%, hypertension was 18%. This is what I found interesting right here, is a lack of eating fruits and vegetables. If you don't eat enough of your fruits and vegetables, that accounts for 14%, where diabetes was 10%. Now keep in mind, if you have diabetes, you probably have the high cholesterol, and all these things kind of run together too, so it adds up. But this kind of identifies the targets for treatment, how to avoid heart disease. There's an app for this too. If you need an app for this, you can kind of do this. It's kind of interesting. I did this on my patient just to see. So I put in his numbers here, okay? I put in his age, his cholesterol, and all this thing. In the middle column here, you can see his HDL was 30, LDL was 127. Not too bad. His blood pressure was quite high, 198 over 123, but that was when he was having the pain. He's not a smoker. He was being treated for hypertension. So the one on the right side, you can see that they said his 10-year risk of heart disease was 25%, but his lifetime risk was 69%. But the cool thing is, if you want to click on these little buttons here, I clicked on just maybe he needs to start a medicine, the statin, for his cholesterol. If you just click on that one, it'll show you that reduces that number down to 18.9% if you take a statin. So it's kind of neat. They've got all the calculations and this kind of thing. So you can look through all that and kind of figure out your own score. So let's focus on cholesterol. So I put this picture in here because you can kind of see what the plaque buildup in the artery looks like. That's that yellow stuff inside the artery. When that limits blood flow downstream, you do actually have death of the muscle because it's not getting the oxygen or the nutrients it needs to survive. The cholesterol goals, total cholesterol, you want it less than 200. This is right off of what they print out at Mercy where I work. All right, right on the thing. So you probably want to be a little more aggressive than this, would be even better. But this is their stated targets, okay? So this is just for the average person. Desirable is less than 200 for total cholesterol. And they want the good cholesterol more than 60 and the bad cholesterol less than 100 unless you have known heart disease and you have multiple risk factors. So if you have a bunch of different risk factors, they really want to tighten it up and be less than 70, right? And then triglycerides should be 150 or less. So let's go over some studies about statins. You know, doctors always want to put you on the statins, right? This part of the study is primary prevention, which means they have not yet had a heart attack. So this is just average Joe that's just there, and he shows up and he's got high cholesterol. All right, so the NNT is the number needed to treat. So if you treat people for 5 years, if you have 104 people, you'll have one that prevents a heart attack for 5 years. If you have, you can prevent a stroke if you treat 154 people. But side effects, the number needed to hurt or harm, is the NNH. 1 out of 50 will get diabetes, they say, from statins, directly from them. 1 in 10 will have some muscle damage. You know, it's one complication that I do see is aches and pains, obviously, from a rheumatology standpoint. People have hurting muscles, and a lot of times it is this kind of medicine. So the take-home message is it takes 5 years of taking a statin every day. It lowers your risk of having a heart attack by 1.6%. Okay, but you have a 2% chance of getting diabetes. So those odds are not really all that great. You know? Now, what if you've already had a heart attack? This is called secondary prevention. So you've had your heart attack, you treat that group of people for 5 years. Numbers look better, right? These people are more at risk. So 83 people, you treat 83 people, you save 1 from having death. And 1 in 39 people can prevent heart attack. And if you think about it, that's why they do it. I mean, they want to try to lower those numbers. They'll take a risk. I mean, doctors are here to help. They want to lower all your risk as much as they can. That's not really all that fantastic, but it's better than nothing, right? So take that. Again, you still have the 1 in 50 that get diabetes. And then the muscle damage. Okay, another way to look at it is 5 years of daily statin. You avoided a heart attack by 2.6%. So that's actually better, right? So it's better than your risk of getting diabetes. So that's why they do that. Okay, here's some other treatments for cholesterol. I'm not going to go through all of this, but there's something interesting I've found, and this is, it's a PCSK9 inhibitor. Okay, and that's actually what they call it. There's 2 kinds right now. They're injections that you can give yourself, and they lower your cholesterol pretty rapidly. So these are probably for your sickest patients, right? So it can drop your LDL by 62% in a year. Okay, so the long slender thing is an injector pin. You inject yourself with that once a month, or once every 2 weeks if you're really bad. The big square one is you put it on your skin and it injects for 9 minutes actually. But they're pretty effective. So when you can't lower somebody's cholesterol, it actually does help. Then there's all these other options. They actually did a small trial on garlic, and it said it didn't really help much. Hypertension. Now, Dr. Mullins is going to do hypertension lecture tomorrow. Yeah. So I'm not going to go over this too much, but let me hit the high points here. So it's one of the biggest risk factors. It accounts for 47% of all heart attacks globally. And it accounts for 54% of strokes globally. And for patients that actually have hypertension, if you lower your systolic blood pressure by 10 points, or your diastolic blood pressure by 5 to 6 points, it lowers your risk of having heart disease or heart attack by 16%. That's actually pretty impressive too. And the risk factors, again, these are additive, okay? So blood pressure reduction is even more important if you've got multiple risk factors like high cholesterol or smoking. There's a linear relationship between blood pressure and cardiovascular risk. So the higher the number on your blood pressure, the higher the risk. So people with the highest number actually benefit the most from treating it, right? Also, the longer a person has had high blood pressure, the more likely they are to have high heart disease. So it's not just a one-time thing. It's kind of 10 years, 20 years. They call it a silent killer because it kind of sneaks up on you. People who treat it early will have the most benefit and hopefully avoid having any heart disease. Okay, so let's review these. Do the blood pressure medicines work that they give you? So you got to treat 125 people to prevent 1 death. You got to treat 100 people to prevent 1 heart attack for 5 years. And then you got a number needed to harm 1 in 10. So people will stop their medicine because they have a side effect. And some of these side effects aren't really that big. Like an ACE inhibitor, you can get a cough. You just stop that and try something else, right? But that's 1 out of 10 will have to stop their medicine because they have something. But 9 out of 10 don't, right? If you treat people for 10 years, the numbers look better. You cut them in half, really. So it's 1 out of 63 prevent death. 1 out of 50 prevent a heart attack. If you do it for 15 years, numbers look pretty good there. 1 out of 30 will prevent death, and 1 out of 25 will prevent a heart attack. Okay, so people with the highest blood pressure benefit the most from blood pressure reduction. And they do work as long as you can tolerate them. Okay, here's an interesting fact, is there's now evidence that dropping your systolic blood pressure below 150 has no long-term benefit, but it can increase your risk of harm, especially in the elderly. They're more apt to pass out or fall or something like that. They have more complications. Okay, let's go over smoking. As of 2017, so last year, 15.2% of Americans smoke. Yes, Dana? Sure.
It said there's no evidence for dropping the low. That's with medication, right?
Right.
Benefit.
Oh yeah, clearly, yeah, that's a good point. So if your blood pressure is normal, obviously you have less risk. It's like if you've got high blood pressure and you drop it and your target, this is basically for doctors, I guess. So you want to, if your target is to lower somebody's blood pressure, you don't want to target below that necessarily. That's a good point. Smoking, so 15.2% of Americans smoke. In Arkansas, it's a little higher, it's 25%. Globally, 1.3 billion people smoke. That's amazing. In developing countries, it's worse. The rates are about 50%. The majority of people will start before the age of 18. And I've heard places say if a child doesn't smoke it before 18, they're unlikely to start smoking. Very few people pick it up after that. Many smokers don't believe that smoking is actually bad for them. I found that hard to believe too. They don't believe it's harmful to those around them either, which is secondhand smoke, right? So they did this study of 737 smokers were asked. 60% did not know that they had an increased risk of a heart attack. I guess they're probably thinking lung cancer or something else. Okay, and there's the Inner Heart study again, 52 countries. People that smoke 20 cigarettes a day versus those that never smoked. Women have a 6 times higher risk of heart attacks. Men have a 3 times higher risk of heart attacks. If you smoke 2 packs a day, which is 40 cigarettes, they had 9 times the risk. So it's, again, you see a dose-dependent relationship. It goes up the more you smoke. How about after you've had a heart attack? People who continue smoking have an increased risk of having another heart attack or dying from it. And those who quit smoking, this is good news, they have a reduction in risk over time. So the longer they can get off of smoking, you can return back to normal levels. It takes a while, but you can. So the longer you're smoking, the higher risk you have of heart disease. Makes sense. The risk of cardiovascular disease is present even for low doses. I found this interesting. Smoking 1 cigarette a day is associated with a 50% increased risk of a heart attack and 25% risk of a stroke. I mean, that's still, it doesn't seem like much, just 1 cigarette, but it still causes all this inflammation in your blood, causes an increased risk of a heart attack. How about cigar smoking? They say 4 cigars are about the same as 10 cigarettes. So again, they saw a dose-dependent relationship. So the more cigars you smoke, the higher risk of heart disease. What about pipe smoking? Pipe smoking is hard to study. There's not as many people that smoke pipes. But they did see an increased risk of mortality, less than cigarettes. And they think that's probably because they're not inhaling as much. Secondhand smoke. Most of the studies that I reviewed showed a modestly increased risk of heart disease just from being around people that smoke. How about smokeless tobacco? They did a study, a Swedish study, and they did 6,000 construction workers. They followed them for, I'm not sure how long it was actually. They showed that they had 2 times the risk of cardiovascular disease just from that. And among those who had a heart attack, those that quit using the snuff had a significant reduction in mortality. And then e-cigarettes, I thought that was interesting too. They did a recent study just a couple months ago at the University of California at San Francisco. They looked at 70,000 people, and they showed a 2-fold increased risk in heart attacks. Let's move on to obesity. So obesity is really a BMI, or body mass index, more than 30. Okay, and there's a continuous linear relationship between obesity and cardiovascular risk again. So the heavier you are, the more likely that you are to have heart disease. It's a linear thing. So if you look here at the graph on the left, America is getting bigger than ever. So if you look back in the beginning, so around 2000, Y2K, our risk of adults is the red line. That was 30% back then, and it's now almost 40%. For children, it was 13%, now it's 18%. And I thought this was interesting. I looked at the states. We ranked number 3. We're tied with Alabama for that. And West Virginia and Mississippi are ahead of us still. But that still puts us in bad company, right? Okay, diabetes. Dana went over this really good, so I'm not going to spend too much time on it, but let's, you're more likely to have a heart attack, obviously. The risk is doubled in men and tripled for women. And when they do have a heart attack, they have greater damage if you've got a history of diabetes. They're more likely to have multiple vessels attacked at the same time. So they have less reserve, basically. And they have fewer collaterals, which are the small little vessels that feed your heart. They branch off, and they get kind of affected quickly from diabetes. So there's less reserve there. Often diabetics will have a silent heart attack because the nerves are affected in their heart. So they can have a heart attack and not even feel it. They're 15 years younger, and they're more likely to have multiple different risk factors. So they all have a synergistic relationship, like we mentioned before. So if you've got diabetes, you usually have high cholesterol and obesity and high blood pressure and those kind of things. They run together. And the risk for heart disease is so elevated that diabetics are assumed to have heart disease even if they've never been told they have it. I've seen that in the emergency room. Somebody comes in, they're diabetic, we just assume they have heart disease. Okay, so type 2 diabetes carries the same risk of future heart attack as somebody that's already survived a heart attack, which is probably the highest group, right? So if you've already had one, you're likely to get another one. Type 1 diabetes is even higher. The more poorly controlled your diabetes, the more likely you are to have extensive disease. So they did a small study here of 315 people that came in with chest pains. They did a heart cath on them, and if their hemoglobin A1C was 6.7, they had, on average, 0 vessels affected. But if you, as you go up, you get up to 10.4 on your hemoglobin A1C, and they usually had the triple vessel or 4 vessel disease. Let's talk about exercise. So some motivation is required. American Heart Association recommends 150 minutes of moderate activity every week, and you can break it up, just like Dana said. You can break it up into 30 minutes a day for 5 days a week, or you can have 10, 15-minute sections. Excuse me. And also they recommend 75 minutes or vigorous activity a week. So it's either or. So if you can't exercise vigorously, I got one. Yeah, thank you. If you can't exercise like moderately, if you can do vigorous, that's even faster. And okay, let's move on to aspirin. I found this interesting too. So this is a short study. So these people had not had a heart attack or stroke. Number needed to treat to prevent a heart-related problem was 1,667. That's a lot of people. 2,000 people you'd have to treat to avoid 1 heart attack. 3,000 people to prevent a stroke. But 1 out of 3,333 had a bleeding event, a major bleeding event, and that was determined to be like if you had to be admitted to the hospital and get a transfusion. So that's pretty big. So they don't recommend aspirin for prevention of your first heart attack. But they do for secondary prevention. So the number needed to treat here is 1 in 50. And these people, this is a longer study, so it's 2 years. So you have to treat them for 2 years to avoid a heart attack in 1 out of 50 people. And it prevented death in 333. Yeah. And then, but again, you had the number needed to harm was 1 out of 400, and that's a major bleeding event. So they did recommend aspirin. Okay, so fruits and vegetables. Like we said before, the more you eat, the better off you probably are. And this is proof. Nurses' Health Study, they looked at 110,000 people for 14 years. This is a pretty big study, long study. A higher daily intake of fruit and vegetables resulted in a lower risk of heart attacks and strokes. And people that averaged 8 or more servings a day were 30% less likely to have a heart attack than those that average only 1.5 servings a day. Which is kind of interesting. That sounds a little better than the medicine, doesn't it? Another review of long-term studies in the U.S. and Europe found that people that ate 5 servings a day had a 20% less risk than those who averaged less than 3. The most famous probably is the Mediterranean diet. They looked at that for primary prevention. They looked at 7,000 people for 5 years, and the people that hadn't had a heart attack. Number needed to treat here was 1 out of 61. And there's really supposedly no harm, unless you don't like the diet, I guess. Secondary prevention, they looked at 600 people for 5 years. These people had already had a heart attack. The number is 1 in 18. So you got to give people, 18 people, 5 years of this diet, and it prevents the heart attack. 1 in 30 prevented death. That's pretty good. So what is the Mediterranean diet? I guess you better ask Dana, but what I read is it's abundant in fruits and vegetables. As olive oil is a principal source of fat. It's a certain type of fat, really. They're pretty low in fish and poultry. Red meat was very low. Red wine, they had low to moderate, actually. And dairy was mostly cheese and yogurt, which was less butter and less cream, really. But the diet is really low in saturated fat and low in omega-6 fats. And it's high in omega-3s and fiber and antioxidants, vegetable protein, and the B vitamins. How about fish oil? So the DART trial was interesting. Back in 1989, 2,000 men were followed after a heart attack. They followed them for 2 years. And increased consumption of fatty fish lowered mortality by 29%. So they got all excited about that. And that was mortality, so that's pretty good. But they did a DART-2 trial in 2006. It was a bigger trial. They had 3,000 men with just chest pain. And they followed them 3 to 9 years. And increased intake of fish had no effect on mortality. And significant increase in sudden cardiac death in people that were taking fish capsules. So nutritional supplements do not necessarily have the same benefits as foods from which they are derived, the whole foods. How about vitamins and antioxidants? So 50 randomized control studies were reviewed. They did almost 300,000 people reviewed on these things, and only there was no benefit, but there was not really much harm either. But they did kind of parse out the data, and they did a subgroup meta-analysis, and they said that there might be some protection with vitamin B6 and vitamin E. But those were only found in studies that were sponsored by vitamin B6 and vitamin E. Again, the authors suggest that the results should not be applied to fruits and vegetables, which have shown better benefit. Okay, what if all that other stuff fails? How about angioplasty? Okay, they did a big trial called the Courage trial, and they did 2,000 people with stable ischemic heart disease. They're really bad sick people that are coming into the emergency room. These are guys that just have heart disease. They compared optical medical management versus optical medical management plus angioplasty. So did that help at all? Really, there was no difference in survival out 15 years, which is pretty amazing. Let me show you this video here. Yeah, oh, here we go. This is what an angioplasty is, I think.
Cardiac catheterization is used to find out if you have heart disease or to treat your existing heart disease. During the procedure, your doctor will give you local anesthesia to numb the insertion site, usually the groin or arm. He or she will make a small incision in the skin over the artery, then insert a sheath or plastic tube into the blood vessel. Your doctor will insert a long, flexible wire and advance it to the coronary arteries. A tube, called a catheter, is then put through the sheath over the guide wire and slowly advances the catheter to your heart. To test for heart disease, your doctor may perform coronary angiography, injecting dye through the catheter into the coronary arteries, which are the blood vessels supplying your heart muscle with oxygen and nutrients. X-ray pictures, called angiograms, are taken of the dye in your heart to check for blockages or narrowing of the arteries that can be due to coronary artery disease. If you have coronary artery disease, your doctor may treat it immediately with a procedure called coronary angioplasty, with or without stent placement, which will open your narrowed or blocked coronary artery. To do this, your doctor will insert a balloon-tipped catheter through the sheath, thread it up to the narrowed artery, then inflate the balloon to compress the plaque against the vessel wall. A stent may be placed within the artery to keep the artery open, resulting in an improved blood flow. At the end of your cardiac catheterization, your doctor will remove the catheter and sheath and close your incision.
Okay, so that's, I found that interesting too. I used to work at Kauai Medical Clinic. We were there for, I don't know, a year and a half, something like that. One thing that was interesting is the cardiologist there could not do that procedure. The reason they couldn't do that procedure is what happens if there's a complication. We didn't have a cardiothoracic surgeon there to fix it. So you have to go over to Honolulu to have the a heart cath done, anything like that. So they could only do optimal medical treatment there. How about if you have a bypass graft? Okay, this is pretty radical. So they only do this in people that really have some major problems. So you have to do that to 1 out of 25 people to prevent death. 1 to 10 to 14 prevented a non-fatal heart attack. But if you have the widowmaker, okay, and that's the left main, it's 1 out of 4 that prevents you from dying. And if you have triple vessel disease, that's usually when they do it, is when you have 3 or 4 vessels that are blocked. It's 1 out of 15 people will prevent death. Number needed to harm, these aren't insignificant. 1 out of every 82 of these they do will have death from the procedure. 1 out of 100 will have a stroke. 1 out of 43 have kidney failure. 1 out of 3 to 1 out of 5 will have cognitive decline. So they actually have, it's from the anoxia during the procedure. A lot of times they'll have some actual brain damage. Okay, so coronary artery disease is reversible. This is the good news of the whole talk. Okay, 1951, 2 guys named Strom and Jensen reported a profound decrease in circulatory diseases in Norway after World War II, when the Germans confiscated the country's livestock, forcing them to eat plant food. So that's interesting, huh? Autopsies of young people between the ages of 17 to 35 that had died from other reasons, from like accidents or suicides, have already had coronary artery disease. That's not good news, but that just shows you it starts really early. Coronary artery disease is very rare in Okinawa, Papua New Guinea, rural China, and Central Africa. It's almost unheard of in those places. And why is that? It's because they have primarily plant-based nutrition. They eat very minimal animal products in those places. It's interesting. So this guy, Dr. Esselstyn, Esselstyn, I guess is his name, 1985, he did a study because he knew these facts, he'd learned these facts. He had 18 patients he put on whole food plant-based nutrition. Prior to starting the study, just in these 18 people, they had 49 cardiac events despite optimal medical care with doctors. And he is a doctor at a Cleveland Clinic, so those doctors weren't too shabby. During the 12 years of this study, when he did this, 17 of those patients had no further cardiac events. So you're taking people that have really had a bad history and you change the event right there. 12 of these people had a heart cath afterwards. And and most of them had no change, and they didn't get any worse. But 4 of them actually showed some reversal, which is really encouraging. So they actually saw a reduction in the plaque buildup. He did a bigger study in 2014. He had 198 patients in that. All had really significant coronary artery disease. They did 4 years of follow-up, and during that time, 99.4% had no further major cardiac events. 93% had an improvement in their chest pain or angina. 21 of those people decided to go back to their old diet, and 13 of those people all had cardiac events in 4 years. That's a short time, just 4 years. So compared to conventional treatment, this whole food plant-based nutrition shows a 30-fold reduction in major cardiac events. Pretty impressive, 30-fold. That's pretty good. We don't have too many medicines that can do that. So in summary, current efforts in cardiovascular medicine like drugs and stents, bypass surgery, they help, but they can't cure or stop the vascular epidemic, and it's financially unsustainable. And increasingly you'll find patients cannot afford treatment, or it's not being covered by their insurance plans. But there is good news. A healthy lifestyle can stop and even reverse this cardiovascular disease. And we just need to spread the word.